talk about clinical applications, which is really the major thing here. It kind of gives this stuff meaning. Okay. Now, we got exogenous substances that you should know about. Okay? Diuretics. These are drugs that are going to make people pee, whether you have congestive heart failure or other kinds of things. You've got to get rid of water. So we have these whole slew of different diuretics. So again, let me draw this thing for you one more time. Okay. And I'm not going to teach you all the different forms. There's no reason to teach you that. This is a pharmacology case. But you should have an idea what diuretics do in general. Okay? They're going to make you pee, which means it's going to decrease the amount of water in your bloodstream, which means it's going to decrease your blood pressure. So these diuretics are used also for as antihypertensive medications. That's what HTN is hypertension. So it's antihypertensive medications. So basically, if you increase the amount of urine, you're going to make your blood pressure go down, right? You're going to, what does it do to blood volume? It makes it go down, which means your blood pressure is going to go down. And if you've got high blood pressure, hypertension, it's going to go down. There's many different classes of diuretics. Again, I'm not going to go through them all. It's just way over the scope of this course. But each class has different mechanisms and affects different parts of the nephron. You do need to know this nephron when you get into your other courses. I guarantee it. Okay? And when you get there, hopefully it'll be a review for you and not that you have to relearn it. Okay? There's one big one I'm sure most of you have heard about, Furusemide, or better known as the trade name, LASIX. This affects this area here. And it's what we consider a potent loop diuretic. They call it a loop diuretic because it deals with the loop of Henle. And what happens here is that it blocks. Now, remember, over here, normally, sodium chloride is going to get reabsorbed. Does that make sense? And water does not. That's how it normally works. But what LASIX does is that it's going to also block sodium chloride from getting reabsorbed. That means the sodium chloride is going to stay in the filtrate. Do you agree with that? Right? I mean, that's what it's doing. If it doesn't get reabsorbed, then it stays in the filtrate. So by the time it gets up here, there's going to be a whole potload of sodium chloride in there. Well, the way the kidney functions in DCT is that, well, geez, if there's a lot of sodium chloride in here, we are not going to be making a concentrated urine. We are not going to reabsorb in these places here. We're not going to reabsorb water. We're going to keep the water in the filtrate so that we keep the concentration in the filtrate at a homeostasis, right, in equilibrium. Does that make sense? Better, yeah? So what happens here is that there's going to be more water that stays in the filtrate. And if there's more water that stays in the filtrate, how much urine comes out of here? More or less? A lot more. All right? So it's going to be greater than 1% than what we see. So that's why they're called potent. It really is going to stop that sodium chloride from going that way. So water remains in the filtrate in DCT, which means that the concentration, it doesn't want to be highly concentrated, so water is going to stay in the filtrate. And when it does, that extra water that is in here is going to go out your urine.
So diuretics typically target specific parts of
Correct.
the body?
Yes. We have one that actually hits everything over here called mannitol. I don't want to get into. I just wanted to give you one example, one that most people heard about. I would imagine that most of you've heard of LASIX, okay? Because it's probably one of the most frequently prescribed medications that are out there. So that's LASIX over here, and it hits that area here. But we have another one that's going to hit here, another one that's going to hit here, another one to hit here, another one over here. And there's a lot of classes of those, and within the classes, there's also a lot of different medications that pharmaceutical companies have because they don't like the side effects of them, you know what I'm saying? So, or the patients don't like the side effects. You want to get something where the patient's going to be compliant, right? Either way, the problem is when you put a lot of diuretics, the person's going to go to the bathroom a lot. So you've got to also consider, are they able to, you know, people who are, let's say, 80 years old with a cane, are they going to be able to run? So you got to put things together. Are they going to be compliant with this? Oh, I don't want to take the pill because it makes me go to the bathroom a lot. That's what it's supposed to do, right? So you have to consider all these different things, okay? Questions about diuretics in general. You should understand at least LASIX. That's going to be one that you're going to need to know for the rest of your life.
So pretty much the traffic flow into the kidney, right?
Keep the what flowing?
The traffic.
Yeah, but it's right, but it's keeping the sodium chloride in here, if you want to say it in the traffic, yeah. But what it's not the sodium chloride that we're making it come out. I mean that's what's coming out here, but it's just we need to get rid of the water. So this, when it stays in the filtrate, it's becoming more concentrated here because it didn't get reabsorbed here. So it's more concentrated here inside the tubule, and that's going to make inside more concentrated. So the water doesn't want to, when it gets to this point here, the water doesn't want to get reabsorbed because that means that it's going to have a very concentrated urine, and we don't want to have concentrated urine. This is where we want it to actually cause the concentration, but we don't need it up here. So the water stays within the filtrate, and it makes you have more water come out here. We're using the feature of keeping sodium chloride in the filtrate so that you can pee out a lot more water, so the water stays in there. Is that clear? Yeah?
So what is in there so that it doesn't become too concentrated?
Correct.
Okay.
It stays dilute then.
Yeah. Okay.
Clear with that? Because normally we have sodium chloride that comes out, so we don't, when it gets up here, it's not concentrated, so the water is going to get reabsorbed. But if you put more concentration here, then the water is going to, I wouldn't say secrete it, but it stays in there. So that means you're going to pee it out, which is what you want to do. You want to decrease the blood volume by peeing it out. Okay?
So all that is the purpose of controlling the blood pressure, right?
Yeah, that's it. Yeah, diuretics. Yep, it's anti-hypertensive. All right, let's do this really quick. We did the alcohol thing. Remember how if we drink alcohol, we have the posterior pituitary and anterior pituitary. Remember, ADH is going to target here. It comes from the posterior pituitary. What alcohol does, and ADH is going to reabsorb water, antidiuretic hormone, also called vasopressin. This comes out. So what alcohol is going to do, and I abbreviate alcohol like ethanol, it's going to block this, which means ADH isn't going to come out, which means that water is not going to get reabsorbed. You have a lot more urine that comes out of here. Does that make sense? Right? That's pretty straightforward. So that's what's happening with that. Again, you're going to have to go back to your endocrinology, which is good review for the final exam anyway. But that's what's happening. It inhibits that, and it does all these things I just explained. Caffeine, I think I talked about that in a little video. But what happens here, very quickly, okay? So what's happening here is the afferent arteriole, glomerulus, efferent arteriole. Here's Bowman's capsule, and there's the PCT, right? So yeah, it's basically doing this, so I'm just reversing. Does that make sense? So what happens here is that normally there's this, and I kind of showed you before, there's like this little and I can't really draw it, but this little monkey over here, tail there, his legs, got his hands over here. This little monkey over here, and he's at the PCT. And normally what comes out of here is going to be sodium chloride, water, all that stuff. But let's say little bananas come out. All right, let's just use bananas. So you have these little bananas that are coming out. And as it comes in the PCT, the monkey can grab the bananas. Reabsorption, right? It's going to reabsorb. The monkey's taking the bananas and reabsorbing the bloodstream. That's what normally happens, right? Now what happens here is that what caffeine does is that we are going to vasodilate the afferent arteria. It's going to get bigger. Does that make sense? If you open this up, is there going to be a lot more bananas coming through here or a little bit?
More.
Much more. It's going to go faster, is it not? Right? If you take that one lane in the highway and you're going 60 miles per hour, and now you open up to 3 lanes, aren't you going to be able to go faster? It's the same thing, okay? So you have more going through there. This is what caffeine is doing. Caffeine is going to vasodilate these afferent arteries. When it does, this is going to go very fast, is it not? If it's going very fast, is the monkey able to get a lot more of them, or are they going to be able? Are they going faster where he can't grab them all? He won't be able to grab them all. Does that make sense? So what happens to reabsorption at the PCT? Does it increase or decrease? It decreases because the monkey can't get all those. If he normally can get 65 bananas out of here, he can maybe only get 50. So the reabsorption happens less. So therefore, instead of 65% that gets reabsorbed here, I'm just giving you numbers, 50% only gets reabsorbed. That means, do we have more sodium chloride in here or less? More. So by the time it actually reaches up here, and then we got the juxtaglomerular apparatus that we talked about before, it's going to pick up that there's a lot more sodium and chloride over here. As much as I showed you over here, if there's more sodium chloride because this just opened up, the water stays in here, in the filtrate, for the same reason here. So now they're going to be peeing a lot more. That's how caffeine works. It vasodilates the blood or the arterial, afferent arterial, and that increases the GFR, which means you're going to decrease reabsorption of water and electrolytes of the PCT, even to 50, I don't know, give you the number, which means you're going to increase the urine output volume because it's going to be more concentrated when you get to the DCT, and water doesn't want to go back and get reabsorbed. It wants to stay there to keep it diluted. So water goes out this way, and that's why caffeine makes you pee.
So caffeine and alcohol kind of do the same thing to your body, just in different mechanisms?
Different mechanisms, way different mechanisms.
Dehydrate you and make you pee more, right?
I'm saying, say it again?
They dehydrate you and make you pee more, right? More or less. Because you're getting rid of water, right?
From which one?
From both.
Sure, absolutely. This one is stronger though
Okay.
than that, but absolutely. You drink a lot more caffeine, yeah. It's kind of an interesting thing. The more caffeine you put in coffee, the more you want more coffee. See how it's like a ploy to make you buy more coffee? All right? They know how to work on that. So does that make sense? Hint, hint. Do make sure you know how, at least basically, let's say LASIX works, how alcohol works, how caffeine works. There will be questions. You need to know how that works. You can't really talk about these things if you don't even know how the kidney works normally. Okay? Fair enough? All right? Now, let's talk about hypertension. I know everyone in this room knows about hypertension. But now let's talk about some basics. What normal is not what it was. About 10 years ago, they just threw this away. 10 years ago, they used to say 120/80. That's what you want your blood pressure. Not anymore. Now they're realizing people with 120 over 80, they get high blood pressure earlier than most people. So now what they're saying is 120 over 80 is pre-hypertensive. So now you want to keep your blood pressure less than 120, less than 80. Ideally, you could say 175, I'm sorry, 115 over 75. That's ideal. But 120 over 80 is no longer acceptable. They want it less than that. Okay? So you can break up there, all right? Pre-hypertensive is 1 to 139 over 80 to 89. High blood pressure is anything 140 over 90. And they break it down into these other groups too. Okay, stage 1 and stage 2. So there's two types of hypertension. And you should know these. There's one that's called essential hypertension, which most people have. In fact, people who have hypertension, 95% of them have essential hypertension. It's also known as primary hypertension. And basically, it's idiopathic. We don't know the reason why. We think it has something to do with just the arteries themselves getting harder, instead of instead of your arteries being like garden hoses, they're more like lead pipes. Arteriosclerosis is actually contributing to this. But what's causing that arteriosclerosis, we don't know. It's idiopathic. Idiopathic means unknown cause. So 95% of them are like this. There's also 5% that's non-essential hypertension, meaning we have a direct reason for it. Okay? So we call this secondary hypertension. 5% have some kind of identifiable reason or cause for that high blood pressure. Okay? And the most common reason that someone has non-essential hypertension is renal stenosis. We've learned about stenosis, mitral stenosis, and bicuspid, or same thing, but tricuspid stenosis. Stenosis is a fancy word for narrowing. So you have a narrowing of the renal artery. Renal stenosis is the most common cause, MCC is most common cause of non-essential hypertension. And it's usually due to eating all that wonderful cholesterol, right? Atherosclerosis to the renal artery. So let me explain to you what this renal stenosis is, because you should understand the mechanism how this happens. First off, to kind of show you in this picture here, you get a close-up of the renal artery, and you have this atherosclerotic plaque over here, making this blood vessel have a narrowing there. And you can see it happening on there. When you do radiography, you'll see those kinds of things. Okay? So, how does renal stenosis cause hypertension? And it's really everything we talked about in here, and I want you to see what's going on. We'll go step by step. Put your pencils down, you can see step by step. First, you have these plaques in the renal artery that's going to cause narrowing. Is it not? Which means, if that happens, the blood flow to the kidney is going to decrease. So in this case here, it's not vasodilating, so you could have renal stenosis is going to cause a narrowing over here. Which means if there's going to be a pinching over here, is there going to be more blood flow going to here or less?
Less.
Less. Less blood flow to the heart, or to the kidney, I'm sorry. Okay? Sometimes you'll hear an abdominal bruit. We talked about, no, we didn't talk about bruits, but basically, you put your palm on the person's belly over here while they're lying down, and as blood is going through there, you'll feel like a buzzing, and we could actually see that, but I don't want to ask you about that. So you have this decrease of blood flow to the kidney, which means we're decreasing the blood pressure to the kidney, is it not? Less blood flow there. All right? It's not really happening here at this level. It's happening at the renal arterial end. I'm not arterial, but at the renal artery. But there is blood flow that's going to decrease in the renal, the afferent arterial, right? You have less blood going through the renal artery means that there's less blood going to the afferent arterial. right? Which means the blood pressure is going to decrease over here. And like we saw before with the juxtaglomerular apparatus, it's all going to affect that. So you're going to decrease the blood pressure at the afferent arteriole. All right? Renin gets secreted through that whole mechanism. I'm not going to go through it again with you guys, but there's going to be renin that gets released because there's less pressure, right? It senses there's less pressure there. So therefore, you're going to decrease the GFR. If the blood pressure is going to be lower over here, that means these are going to be slower, these bananas. Now, think about it. If these bananas are running slower over here, this monkey, do you think he could grab more bananas or less? More. So instead of 65 bananas he's collecting 75. So reabsorption increases at this level here. Does that make sense? Okay? So you decrease the GFR, you decrease the volume of filtrate, you're going to increase reabsorption at the PCT. The monkey's going to be grabbing more. Therefore, you're going to have less sodium in the filtrate because more of it got reabsorbed here. Does that make sense? There's less that come up here. This is going to sense low blood pressure. So the macula densa is going to secrete these paracrines and tell the JG cells to release more renin. Remember, the macula densa, which is part of DCT, senses, it's a chemoreceptor, so it senses less sodium. It's an osmoreceptor, osmo meaning concentration. We're seeing less concentration here, in this case sodium. This is going to tell the JG cells, the macula densa will tell the JG cells that there's a low amount. You better go and release renin to get your blood pressure up. The big cycle, okay? So this leads to much more renin gets secreted from the JG cells. You're going to increase the renal secretion, which means you're going to increase blood pressure, i.e. hypertension. This is how renal stenosis causes hypertension. And you should know this whole thing. It puts together a lot of things.
Does it make you pee more or less?
Less.
Okay.
Less. Because it's going to put more fluid back into the not ocean, but into the bloodstream. All right? And they'll want to, that's where it gets, I don't want to get into the mechanism of how to treat this, but a diuretic would be helpful because it's going to keep it here. But if they already have kidney disease because it's less, because remember, that's when you have renal, if you have renal stenosis, so this renal artery is not bringing in blood into your kidney. You got to keep two things happen, or you got to think that there's two things happening. There's less blood flow going here, so going to the nephron, but there's going to be less blood flow going to the efferent arteriole, which goes to the peritubular capillaries and the vasa recta, which means there's less blood flow going to the tubes themselves. Remember, the tubes are tissue that need oxygen and need nutrients. The tubes themselves. So that we're cutting down the nutrients to here. So this will also lead to kidney disease because now your kidneys are going to start dying because there's less blood flow to the kidneys itself. Here at the GFR level, and also here at actually the cells of the tubes are getting less nutrients. It's a double whammy. Okay? So this will decrease your urine output. Okay? All right. The rest of this, I think you guys can handle by yourself. Just look over it. This is just putting down certain things here, but it's really self-explanatory. Nephropathy is a fancy word for kidney disease. Polyuria means a lot of urine coming out. Oliguria, very little or scanty amount that comes out. And auria means that there's no urine coming out. Right, pretty straightforward on that. All of these. Then I have other terms here like frequency. You can see it on here. They're pretty straightforward. I don't want to go into it. You should know them. They're flashcard kind of thing. Incontinence I talk about, retention of urine. Dysuria is burning of urine, painful urine. Okay. Hematuria, blood in your urine, right? You shouldn't have that. Glycosurias, with diabetic mellitus patients have glucose in their urine. Ketonuria is that ketones in there. We talked a little bit about ketones, or we will, actually an acid-base balance, and we'll talk about that. They're byproducts of fat metabolism. We have proteinuria and albuminuria. We shouldn't have proteins in the urine. So this is if there is, because there's big holes in the Bowman's capsule allowing the proteins to go out there, you shouldn't have that. And by the way, you get like a foamy kind of, when someone pees with proteins in the urine, it's lighter than water, so they actually, heavier than water. But you get these bubbles that appear on the, like a foam that appears on top of the urine in the toilet bowl. Bacteriuria, there's bacteria there, and we also have pus in your urine. It becomes this, almost it looks like foam on the top of the urine in your toilet bowl, but anyway, there's be pus in there. Glomerulonephritis is an infection from strep throat, and that it's strep throat, and if it stays in your body, it can actually cause this disease where your these antigen-antibody complexes just clog into the nephron itself, in the glomerulus. But this is the reason why we give penicillin to people who have strep throat, is to prevent this from happening.
So is it the same virus?
Same virus, no, or bacteria.
Bacteria.
Yep, same bacteria to do this. It just goes down to the kidney. Okay, but that's why we want to make sure the kids, you know, the throat here. Oh, another thing is the strep. There's a lot of things that, you know, that's why I want to get into microbiology. Streptococcus infections. They start off over here. They go into your lungs, but they could definitely go into the kidneys, to the bloodstream, and cause this whole thing. Uremia, I think I explained that. When you have a lot of urea that sits in the bloodstream because the kidneys are not being able to filter it out, then it starts building up in your bloodstream. It goes to the brain. You start off being anorexic. Then you get very tired, lethargic. You go low mental acuity. Oh, hi, mama. I'm not your mama. I'm your son. You know, it gets confusing. And you go into a coma. This is the way that I would wish, if I had to go, this is the way I want to go. It's a very peaceful way. It's hard on the family. You get all this confusion, but it's very peaceful. There's no pain with this. But that's what happens, especially with renal disease. Urinary tract infections can happen anywhere in the urinary tract, you know, the kidney, the ureter, or the urinary bladder, and they would get, it's a, what do you call it? Most common cause is E. coli. You've probably heard of E. coli. That's what that is. What else do I have here? And this is just showing in different places you'll have a urinary tract infection. Same thing here. So really the biggest places are your kidney, your ureter, and your bladder. But you could also have it here, but we have other reasons that we call urethritis, sex transmitted diseases. Just keep in mind too, when you do pharmacology later, this is where it comes in very important for you to understand, how do the medications get excreted from the body? Do they get excreted through the urine, or they get excreted by the liver? In other words, does it go out your pee, or does it go out your poop? If you have kidney disease, you better make sure that that medication that you're giving that patient is not excreted through the kidney. Otherwise, it's going to build up in the person's body and can cause problems that way. Does that make sense? You have to try and find something else that goes out through the liver, your poop. You're kind of very limited if you got liver disease and kidney disease. Right? So that's what I'm just saying on there. Diagnostic tests, blood tests. We could do a blood urine nitrogen test that measures the urea in the blood. It also it increases with GFR. Creatinine, as I said before, is massively used for kidney function. Right? If the GFR decreases, you've got some sort of renal failure. Okay? And the way you do it is that if the creatinine goes up, that means the GFR goes down, which means you have some sort of kidney disease. Okay? You have urine analysis tests that you can just do a dip. Culture and sensitivity, where you pee into a cup to see if there's something there, right? Culture to see what's there. The sensitivity actually tells you, okay, you have E. coli there. What's the best antibiotic to use for that? So the sensitivity, what's it sensitive to? So that's what a CNS is. And the best way to do that is when you pee, you've got to do a midstream, right? You learned about this when they ask. To pee a little bit, to clean out the urethra by letting that urine wipe off any residual bacteria that might be on there. And then you pee, let some of that out in the toilet, and then you stop your pee and then put a cup there. So you do a midstream urine specimen. So it's the cleanest specimen. It's not like this, to actually pee in a cup in a stream. It's supposed to be a joke. Okay. And dialysis. Basically what dialysis is, if there's end-stage kidney disease, what it is that we're going to put a kidney outside your body because your kidneys are just shot. They're not working anymore. So we'll put a kidney on the outside. And what they're doing is they're going to have blood coming from the coming from the artery out to this outside machine that's going to filter all your blood and then put this clean blood and put it back into your vein. That's what dialysis is. All right? Dialysis has gotten better. It used to be like 8 hours a day for 7 days a week. Now, correct me if I'm wrong, but I think it's like 3 times a week for about 4 hours. So it's gotten better. It's gotten better. But still, you got to go and do this. You don't want, as we've seen before, and we'll see again, you don't want that potassium to increase in the person's blood. You're going to have cardiac arrest. So you got to make sure that you have that residual potassium outside your body, let alone all the other stuff too. Okay? And that's what they're basically doing. Okay? Very fast way to do that. All right, questions about urology.